PowerPoints all about fungi. So there's not a quiz at all due before I see you next class. But what is due tonight? Yeah, the big virus exam. If you haven't done it already, I didn't look this morning to see who's done it. I know at least one person's done it that I checked, I think, yesterday. But that's due tonight. Otherwise, I don't expect to finish this. Maybe if I talk. So if there wasn't enough to worry about with all the bacteria we covered and all the viruses we went over, we have more things that can cause disease and cause issues for us. Everything in this PowerPoint are all the fungus that can cause, I should say, the most common fungus that can cause human disease. Just like with the bacteria and just like with the viruses, there are more organisms out there. We just are covering the most common ones that you will probably most likely encounter in your careers or in your lifetimes. So in this PowerPoint, we're just going to talk about what is medical mycology, what are the true human pathogens, what are the opportunistic fungal pathogens, and then we're going to talk about some of the superficial cutaneous, subcutaneous mycoses, pretty much the ones that like to grow on the skin. And then we end with some of the, I'm going to say other random fungus with a fun factoid at the very, very end. So medical mycology. So anything that has MYC in it, that myc means fungus, which can get confusing because things that have just MY in it in the medical realm mean muscles. But as soon as you add MYC, it means fungus. So like nothing at all related whatsoever. So, and mycology is just the study of fungus. Medical mycology is specifically looking at the fungus that cause disease. So medical mycology, these are the ones that cause diseases. They're not like the cool fungus that just look pretty out there in nature, the ones you find hanging out on trees. We don't care about those. We care about the ones that cause us issues. So it's the diagnosis, management, and prevention of fungal diseases. Generally, fungus-causing diseases are difficult to diagnose. A lot of them resemble bacterial infections and viral infections. And so if someone comes in, they're like, oh, well, they're tired, they're fatigued, they were out hiking, and now they just have a cough, and it's like, oh, well, they probably picked up something, and who knows what they got it from. But they're generally probably going to suspect a bacterial or a viral infection before they would ever suspect a fungal infection. And with, of course, becoming problems, just like bacteria, these things are adapting and becoming resistant to even some of our antifungal agents. And so some of these are becoming very hard to treat. Epidemiology is where do we get these where do we pick up a fungal disease? Well, fungi themselves and fungal spores are everywhere. Like they're in water, they're in soil, they're all the way up. I think they said like we can find fungal spores like 5 miles up into our atmosphere. So I'm like, they're everywhere. How we pick them up to cause disease, the number one way is inhalation. We inhale the spores. Most of the fungal diseases we talk about today, they're picked up through inhalation. They cause respiratory issues. However, they can get into open wounds. We can ingest some of them and they can cause disease. Number one way we pick them up is through inhalation. Now, because we pick them up through breathing them in or from trauma or if we eat them, they're not contagious, meaning they're not communicable. If I have a fungal disease, I don't cough up spores, and so I don't spread the spores to someone else. They're out in nature where we find them and then we breathe them in. So most are not contagious. They're not communicable. The only exception is there are some that live on the skin that, yes, skin-to-skin contact or touching other surfaces can spread them. We do, however, still sometimes have epidemics where you have a large number of people that have an outbreak with a fungal infection. And it's not because they spread it from person to person to person, it's just because they were all exposed to the same environmental source. Like they all went hiking in the same woods. They all were inside of a building where maybe there's a fungal spores in the air ducts. It's not because they spread it amongst themselves, it's just they all had the same environmental exposure. What makes it hard is they are not required to be reportable to the CDC. So it's really hard to track some of these fungal diseases. I mean, that doesn't mean places don't report it to the CDC when there's different cases of fungal diseases, but it's not required to be reportable. So we don't always know if there's outbreaks happening, so you just hear it from word of mouth. Why is that? No idea. I don't know. Sometimes ignorance is bliss. Maybe I don't want to. Maybe I don't want to know. I don't know. We do group the fungal causing diseases into true fungal pathogen and opportunistic fungi. True fungal pathogens, and there's only 4 of them, these are going to cause disease even in the healthiest of individuals. So you can be completely healthy and you can still get these. So they're called true fungal pathogens, meaning you don't have to be immunocompromised, you don't have to have some other type of random thing going on. It's the healthiest person can pick these up. So they're called true pathogens. And the unfortunate thing for us is they are endemic or naturally found in the Americas, whether North America or South America. And so we're going to talk about the 4 fungi that are considered our true fungal pathogens. But then there's a whole bunch of other fungi that are called opportunistic fungi, which means you generally don't suffer from an infection unless you are at risk from something else. And some of the things that can put you at an increased risk, if you've had any kind of medical procedure done, because now you have open sores, wounds, so whether you have catheter, surgeries, insertion of some type of like heart implant or something, medical therapies, so if you're immunosuppressed, maybe you're going through chemotherapy, something that causes you to just have a reduced immune system, some other kind of drugs like steroids. If you have some other type of disease, if you have diabetes, if you've got AIDS, something that also causes other issues, puts you at a higher risk, or even lifestyle, malnutrition, poor hygiene, drug use, all can put you at an increased risk of developing these fungal diseases. And so opportunistic fungi, the healthiest person generally doesn't get an infection unless something else is going on as well. Now, how many spores that get in your body, so the spore dose, whether through inhalation, open wounds, and how healthy your immune system are the 2 factors that determine how severe your fungal disease is. If you get a high amount of spores and you have a weak immune system, you're probably going to have a pretty severe fungal infection. If you get a few spores in and you're pretty healthy, you're probably going to have a weaker. You're probably not likely to have, the most severe side effects of the different fungal diseases. Now, diagnosing someone with a fungal disease, one of the easiest, best ways to start is to know their patient history. Because when you go in exhibiting, X, Y, and Z symptoms, again, they will always, nurses, doctors will always think bacteria or virus. And so fungal diseases are not routinely tested. And so knowing your patient history of, I just traveled to this particular area, and they're having an outbreak in that area, and I'm immunocompromised, or I had interaction with birds, because birds is another one we're going to come up to. And I'm like, knowing their history are the big red flags. And so those that are going into nursing, chatting with your patients and finding out where they've been can be a huge clue to go from patient to doctor to know, like, hey, maybe we need to test for fungus. They just got done traveling to here, and they just got done doing this cool thing, but it was in a cave, and now they're at increased risk. One of the ways that we can look for fungus is we do have plates. They're called Saboros dextrose agar. And it's a plate that inhibits bacteria from growing, but it doesn't inhibit fungus from growing. And so we have these plates upstairs because we test for them in the next lab if you take mycology here. And so the only thing that's going to grow on these plates is fungus. It was kind of fun. I like testing students, and I had a student, I think it was before COVID, that she's like, I think I have a fungal infection on my skin. She's like, and they don't want to test for it. So I was like, let's test for it. So we got one of these, and we're like, yep, the only thing that was growing on there, and it looked characteristic of one very specific dermatophyte, little fungus that infects the skin. I'm like, make your doctor test you. My little test isn't going to do anything. Other ways we can test to determine if it's a fungal infection is we can just look for the fungal cells. And so we can get any kind of sample from a patient We're usually going to sit there and add something to it to get rid of anything other than the fungal spores. So there is something called potassium hydroxide that dissolves like skin cells. So the only thing that's left is just the fungal cells themselves. And so we can easily see them underneath the microscope. Having too much fun over there. Trees. Mostly, they're becoming resistant to our immune system, so our immune system takes a really long time just to find them, recognize them, fight them off. And the drugs we're giving them, they're starting to become resistant to as well. We also have issues is they're a fungus. They're not a bacteria. They are still an advanced eukaryotic cell. Just like our cells are eukaryotic, so are they. And so because they behave more like our cells, anything we give that can kill them could potentially have side effects for us. And so it can harm healthy cells when we try to kill the fungal cells. Now, one of the things we try to target is a unique thing that fungi have in their cell membranes, and it's something called ergosterol. Now, in a cell membrane, again, they have a phospholipid bilayer on their cell membrane, just like us. They are eukaryotic cells. They do have this little structure, this little purple thing called ergosterol anchored in there. And because ergosterol is unique to fungal cells, let's target it. And the most commonly prescribed antifungal is called amphotericin B. And it recognizes ergosterol. And anywhere it recognizes ergosterol, it attaches to it and it creates a pore, aka a hole in the cell membrane. So it's causing the cell membranes of the fungi to have holes. And again, if that's your outer membrane, you don't want holes in it because stuff's going to leak out that shouldn't, stuff's going to get in that shouldn't, and ultimately will kill the fungal cell. Though, with amphotericin B and recognizing ergosterol, ergosterol is unique to a fungal spore. However, we have something in our cell membrane that sometimes resembles ergosterol a little too much. Any guess? Because it even kind of sounds like ergosterol in the cell membrane. We always don't want a lot of it. That's good. You got to remember, like things anchored in the cell membrane. There's proteins and lipids and cholesterol. So cholesterol, our cholesterol that's also anchored in our cell membrane, cholesterol and ergosterol can sometimes look a little too similar to each other. And amphotericin B can sometimes see cholesterol in our cells and be like, oh, yeah, that looks like ergosterol. And it will create holes in our cells. And so amphotericin B is like our best gold standard antifungal, but it can also create a lot of side effects. And so most antifungals, they're usually treated with, a very short, high dose of an antifungal to try to kill. But we also know this can create damage, so it's given for a very short time. And then you're given a low dose to try to kill any remaining and try to prevent any new infections of antifungals. Antifungals are not given like antibiotics of here, take it for 10 to 14 days and you're done. Antifungals are usually given in a low dose and it's take 3 to 4 months, maybe even say 6 to 8 months. They're hard to kill mostly because of those side effects. Here is my little nickname. Sometimes they call amphotericin B amphoterrible, just because it has toxic side effects. But it's still our gold standard. We have a couple other antifungals that I'll mention, but this one is the most effective one we do have, even if it's got side effects. Now, it would be wonderful if we could just create a vaccine and not get some of these different fungal diseases. Problem is because they're eukaryotic organisms and because they behave very much like our cells, it's hard to find a vaccine that can target specifically the different fungi. We do have some vaccines against these 3 species, or 3 genus of the fungus. They're all attenuated or weakened versions of them, and again, we blasted them with some radiation. So in theory, they shouldn't be able to cause disease anymore. In theory, we still have that worry, though. They are still live organisms. They're just weakened, that they can't cause disease. of, well, what if they change and mutate and then they then cause disease with these vaccines? So we're working on them, but we really don't have a lot of great vaccines for fungal diseases yet. 4 true pathogens. So the 4 true fungi species that even doesn't matter how healthy you are, you can still pick these up and get infected. It's Histoplasma, Blastomyces, Coccidioids, and Paracoccidioids. And some of these are really long names, so if you're like a Scrabble fanatic, you're like, oh my God, I can get rid of all these C's and all that stuff and use, make the longest words ever. Because Paracoccidioids is only the genus. The species is a really long name too. Now, all of these are picked up through inhalation. So if you're going to get one of these true fungal pathogens, you picked it up because you breathed it in. Because we breathe it in, are going to initially cause some kind of lung or pulmonary infection. So your initial symptoms are probably going to be coughing. So many things make you cough, you don't even think about it. Past the respiratory system, it can get into the blood, and then any of them can really spread anywhere in the body and cause issues. Now, any healthy person can develop any and get fungal infections of these 4. Generally, they stay as a pulmonary infection. It's not super common for them to spread out and cause more severe systemic issues. Usually that is reserved for more immunocompromised, but even the healthiest person can develop pulmonary infections of these different fungus. All 4 of these different fungi are also known as dimorphic. The di means 2, the morph means like morphology, or what do they look like. They really have 2 different lifestyles depending on where we find them. If we find them out in the environment, we find them in these long, stringy hyphae. They kind of look like big branches, and then they look like little poofy spores on the ends. And that's how they're growing out in nature, is these long hyphae producing the spores on the end. But they don't look like that when they get in the body. Once you inhale one of those spores, they get in the body and they reproduce by budding. They don't have those long, stringy things. So they behave differently in the environment versus based on the body temperature, and it is temperature-based. Once they get in the body and they have that nice maintained 37 degrees Celsius for a nice long extended, doesn't change, doesn't fluctuate throughout the day, that's what triggers them to go into this one form. When they're out in the environment, generally in a cooler environment that fluctuates, then they grow and reproduce by those hyphae. Histoplasma capsulatum. So the histoplasma is our first of our true pathogens. And Histoplasma capsulatum is the most common fungal disease, even though you probably have never heard of it. It is the most common fungal disease that infects humans. It's mostly found in moist soils, and usually it's moist soils that have a higher nitrogen content. And usually the nitrogen content is from bird droppings, bat droppings. Now, as I said before, all of these true pathogens, we pick them up through inhalation. They get into the lungs and cause a pulmonary infection, which I think I talked about in the next slide. But they can travel anywhere in the body, either by getting into the blood or they can get into the lymphatic system. Where we find Histoplasma capsulatum are all the orange areas. So is it found around here? There are cases around here. The highest concentration of cases is a little south of here, but there are still cases around here. These are just like the endemic areas where it's naturally found, but really that's not that far from us if you go to Iowa. So this is where the highest number of concentrations of this fungus are, but we still have cases around here. Again, most individuals pick it up. They're digging in the dirt. They're out on hikes kicking up dirt. They're camping and digging around or something. I'm like, it's anything to kind of stir that dirt up and so that they breathe in those fungal spores. Now, for a lot of individuals, asymptomatic or like minor coughing. You're like, how do I just breathe in a bunch of dust and you cough? Well, maybe you breathed in some fungal spores too. issues it can cause. Now we're in the clinical, aka disease-causing histoplasmosis. There's 4 major different types of disorders that can be caused. It really depends on where the fungus goes in the body. If it stays strictly in the pulmonary system, just in the lungs, it's called chronic pulmonary histoplasmosis. And you're going to have coughing, but generally a more severe coughing, sometimes even a blood-tinged cough, and it's a chronic cough. It goes on for weeks, if not months. It usually causes night sweats, weight loss. Again, you're just like this nonstop cough that doesn't ever seem to go away. And it's usually a more severe cough and sometimes even a little bloody. And you guess what that resembles? That's a bacteria. Yeah, it very much resembles tuberculosis. Tuberculosis, chronic cough, doesn't go away. Usually that also has night sweats. And again, if a patient comes in exhibiting these symptoms, they will always immediately think bacterial infection before they think fungal infection. And again, that's when you talk to like, oh, you were just recently camping, or, oh, you like to go hiking a lot, or you travel to some of these, endemic areas. Then they can start testing. It can also spread, again, it can get into that blood or lymphatic system. It can get out to the skin and cause what's known as chronic cutaneous histoplasmosis. You just have all these lesions all over your skin. They won't kill you, slightly. If it spreads to different body systems internally, they call it a systemic histoplasmosis. This is pretty uncommon. It usually are those that are in the AIDS stage of HIV infection, where it starts to cause issues with different body systems. But it can grow in the eyes, like inside the eyes. And so if you ever go to the eye doctor and they look at the, get in there and look at the back of your eyes, they look at the back of your eyes, you could have fungi growing back there. That's ocular histoplasmosis. Yeah, it's usually going to cause some blurry vision issues with your vision that would probably send you to the eye doctor. Diagnose, they're generally going to identify the yeast stage that's inside the body. And again, a lot of the yeast, you can see the budding that's happening from them, but it's usually not just like one little bud. It's usually like a whole round circle of buds. Treat it, amphotericin B. It's our gold standard. If it's a kind of a minor infection, they will usually give a weaker ketoconazole. So it's still an antifungal. It's just not as strong as amphotericin B, and kind of less side effects. You're just giving it usually for a longer period of time. Our second of our true pathogens is Blastomyces dermatitis. Is this found around here? Oh, yep. And I actually hear more cases of dogs getting different Blastomyces infections. Why dogs? Like their noses are always like on the ground and they're pawing at the dirt and their noses are right in there. And so it's not uncommon that dogs can get this particular fungal infection as well. Then it's found in rich organic soils, so usually out in the woods where you've got lots of leaf matter that's falling all the time, nice healthy soil. And it's picked up, we breathe it in, and most individuals experience what's known as pulmonary blastomycosis. It stays in the lungs, so it's the most common. For a lot of individuals, asymptomatic or minor coughing. Again, most individuals don't suffer like super severe infections from this particular fungal disease, and after some really annoying coughing for a while, it goes away. It can cause more than just these, asymptomatic or minor coughing. It can spread throughout the body. This is so you can actually see some of the fungus growing in the lungs. It can spread from the lungs, and it can go out to the skin. And it can cause what's known as cutaneous blastomycosis. You end up with wart-like lesions. Unfortunately, they seem to concentrate in the face area, which is where you don't want them. They say they're painless. I don't know. They look painful. It's not a great place to have little wart-like lesions that are not going to go away anytime soon. They can also get in, because they can travel throughout the body in both blood and lymph. They can get into the joints, and they cause what's known as osteoarticular blastomycosis. It can cause swelling in the joint areas. Now, if you talk to your doctor, you're like, my joints are super swollen, they're sore, I've been out hiking a lot in Wisconsin, what might they think you have? What? Lyme's disease from the ticks. Lyme's disease causes inflammation of joints as well. So they're probably going to think, oh, well, you probably have Lyme's disease. And they might even just give you an antibiotic right away and send you on your way. That's not going to help you, though. Again, they will always suspect bacterial or viral before they suspect fungus. Unwritten cases, usually those that have the weakest immune systems, those that are in the AIDS states of HIV. It can cause meningitis. It can affect the central nervous system. It can be deadly. Again, that's usually only the most severe immunocompromised. Healthy individuals can go through everything else. Again, diagnosing it, they try to ID the fungus, specifically the spores that are in the body, and treatment, amphotericin B, usually if it's a more severe infection, or they can give you an oral itraconazole, just kind of like ketoconazole. It's a weaker antifungal for kind of minor fungal infections. You're just giving it for a long period of time. Third true fungal pathogen is Coccidioidomycosis. Again, super long words, great for Scrabble. Caused by Coccidioidomycosis. This is not found here, like in our little area. It's found both in southwestern United States and northern Mexico. I've got a picture on the next slide. It's usually found more in desert areas. So Arizona is one of the top areas where we see the most cases. Again, we inhale a spore. And once that spore gets into the lung tissue, it forms these really big, what they're called spherules. They're little spheres. And it's in these spherules where the fungal spores are reproducing. They're reproducing, they're budding, but they stay in these nice little protected spherules for a while. When there gets to be enough spores, then they burst open and they release those fungal spores into additional lung tissue. And each of those are all going to create their own spherule and produce more spores in the fungal tissue. But finding these spherules is a unique feature to this particular fungus. This is where we find the highest concentration of this particular fungus. So again, not a lot of cases around here. We are not deserty whatsoever. But if you ever travel, or if you have patients that have traveled to these particular areas and they were out in the deserts and they were like, yeah, I was in the desert and we were four-wheeling and it was super cool. And you're like, oh my God, you were kicking up dirt everywhere and you were breathing it all in. And one of the big things is you breathe it in. So it usually causes pulmonary conditions. So coughing, sometimes even blood-tinged sputum. But it also causes usually a pretty high fever. And so a lot of times this is even just nicknamed desert fever. It's so common in Arizona and Southern California. It's just like, oh, you got desert fever, no issues. Because for a lot of people, it generally just stays in the respiratory tract. You're coughing, you have a fever, and it will eventually go away. So a lot of people don't even go in and get diagnosed. But it can spread. Usually if you're immunocompromised, it spreads. So healthy people get it. It's just usually coughing, fever. Disseminates or spreads if you're immunocompromised. And again, it can get into the blood, it can get into the lymphatic system. It can go out to the skin and cause these lesions on the skin. Generally not a deadly fungus. Diagnosing it, they can look specifically for those spherules because that's very unique to this particular fungus. They can also do a skin test, just like they do a TB skin test. So if you come in and you're like, well, the patient's coughing, they've got blood-tinged sputum, they've got a fever, they might think TB. Whether they just do a quick little TB test, they can do this particular skin test as well, and they'll know pretty quickly, if it's one or the other. Treatment, amphotericin B. Again, the gold standard antifungal. That wasn't a big enough word. Here's the bigger word, coccidioidomycosis. Paracoccidioidomycosis. I don't even know how many letters that is. 20? Two? It's like almost the whole alphabet up there. Now, the biggest paracoccidioids that cause us issues is Paracoccidioides brasiliensis. And even based on its name, it is found more in South America. That's where it got its name, was Brazil. It's found also in southern Mexico as well. So again, if you have patients that have traveled, would be a clue. Farm workers are usually the main ones that are the ones that pick up this particular fungus. Why farm workers? Yeah, they're outside in the dirt all the time. They're the ones, they're digging up the field, and if you've ever watched farmers plow, especially on a windy day, they get in there and then the dust just goes everywhere. So they're at the highest risk of picking up some of these pulmonary fungal diseases. So most individuals start with the pulmonary condition, coughing, usually, sometimes a fever, I don't say usually, but a lot of coughing. Again, you have a fungus growing in your lungs, and coughing is your body's way of trying to get rid of things, but it does usually spread, and it usually is a really small dose that's even needed to cause pulmonary conditions and start to spread. And once it spreads, it doesn't go out generally to the skin, it goes out and causes inflammatory diseases of mucous membranes. And so it's going to cause lots of inflammation around inside the nose, inside the mouth, all the mucous membrane lined areas. It's going to cause an inflammation. I thought I had pictures. Nope. Oh, it's not going to be a great fungus infection to have. Diagnosing it, they look for the yeast, and the yeast is unique because the inside of it is hollow. And so it still has budding coming off of it, but it looks more like a wheel, a little circle, with the buds coming off of it. So it has a wheel-like yeast with buds coming off of it. Treatment, any guess? Amphotericin B is the main treatment. Again, gold standard antifungal. Again, because it can cause those side effects, usually a low dose, long periods of time. Again, it's not uncommon that patients will be on these antifungals 3 to 6 months. And if they ask, why do I have to take it so long? Because if we gave you a higher dose, it's going to cause so many side effects. You're going to not probably take it. So low dose, long periods of time. Fungi that can cause diseases throughout the entire body. Usually these are going to be things that cause more severe infections with those that are immunocompromised. So healthy individuals are usually not going to suffer or suffer very much from opportunistic fungi. Again, these are the ones that, maybe if you're immunocompromised, maybe if you just had surgery, maybe, something else is going on that will cause you to actually suffer any severe complications from these particular fungi. So we call them opportunistic. These are all going to be at an increased risk for those that are in the age stage of HIV infection. They're also a little more difficult to identify. Their yeast are not really specific for anything. Now, there are 4 genera that are routinely encountered. Pneumocystis, Candida, Aspergillus, and Cryptococcosis. Some you may have heard of. Do any of them sound familiar? One maybe. Candida, yeah, that's your common yeast that we'll talk about. Others, some people are like, I've heard of Aspergillus. Some people have heard of Aspergillus, probably not the other ones. And so the first one, the Pneumocystis Pneumonia, is caused by Pneumocystis gyrovetsii. And this particular fungus is an obligate intracellular parasite. So just based on its name, obligate, it's required to be inside of our cells. And once it's in there, it's parasitic inside of our cells. Now, that is unique to a fungus. Fungus are generally not obligate intracellular parasites. They can go survive out in nature on their own. It's just, we breed them in and they cause us issues. This particular fungus requires to be inside of the body for it to actually grow and reproduce. So how it gets in there, inhalation. So the spores can hang out, but they're not reproducing out in nature. If you're healthy, asymptomatic, you would have no idea whatsoever that you had this particular fungus in your lungs. But for those that are in the age stage of HIV, sometimes it's this particular fungus that says, okay, other than your CD4 white blood cell count, you start developing some of these unique diseases we'd say, okay, well, you're in the age stage of HIV because you apparently don't have enough healthy of immune system or any immune system to fight this off. It needs the weakest of immune system to cause disease. If untreated, it will cause death. It will get in and literally destroy the lung tissues as it gets in there and kills all of the cells. Now, diagnosing it, they usually will do a sputum sample, and they're just going to look for the spores inside the sputum sample. Again, you're going to be coughing up these spores because there's going to be so many of them. Like phlegm. Yep. Good question. I've probably been using that a lot. Imethaprin and sulfanilamide. The unique part is it's not treated with antifungals. These are not antifungal drugs. It's not the iconazole or ketoconazole, and it's not the amphotericin. These are not antifungals. These are actually antiprotozoans, and I know next class we start getting into protozoans. But these are parasitic drugs. Because this particular fungus behaves like a parasite, it behaves like a protozoan, more than a fungus, more than anything else, we actually treat it with antiprotozoans. It's more effective to treat it with the antiprotozoans than antifungal. So even though it behaves like a protozoan, it's genetically a fungus. Next of our opportunistic is the Candida, causes Candidiasis. And again, usually does not cause individuals and healthy individuals. Candida albicans, for most individuals, I want to say it's like 70%. It's the normal flora, meaning it's found normally in your mouth, so in your digestive tract, as well as even the reproductive tract. We can find Candida albicans. Causes no issues whatsoever, unless something changes. Then it becomes an issue. Transmitted between individuals. If you have this particular yeast living in your mouth and you kiss someone, you shared something, you can give them the yeast. Again, as long as they have a healthy immune system, no issues whatsoever. But if you become immunocompromised, or this becomes issues if your pH of your body changes, especially in the reproductive tract, it can start to grow. This is what causes yeast infections. If something changes, depending on where that yeast is found and where it starts to grow, depends on what kind of disease it can cause. And I've got pictures on my next slide. It generally doesn't get into the bloodstream and cause systemic issues like other internal bodies unless you're severely immunocompromised. So, AIDS. So it's only a systemic disease in AIDS patients. But again, depending on where that yeast goes and it starts to grow and reproduce, depends on what kind of yeast infections we have. Again, it can get into the throat and cause esophageal candidiasis. It can get into skin. It's one big issue with diaper rash. Again, diapers, warm, moist environment. Yeast love it. And they're going to cause a lot of skin rashes. It can get under the nails and cause, it's one thing that can get under the nails and cause issues. It really likes to grow on your tongue, and it will like completely cover the tongue, called oropharyngeal, also known as thrush. So it's really, where does it get and where does it start to grow kind of uncontrolled, unchecked, depends on what disease we consider it is. But it's all caused by that same candida. There is another one that's making the news, so I don't know. You may experience it. It's Candida. Auris. Candida auris is one of these healthcare-associated infections. It's generally only causing issues with patients after they've had some type of routine procedure done. And so that's why it's picked up in healthcare settings, and so it's considered a healthcare-associated infection yeast. Problem with Candida auris, it currently has no treatment. We have no antifungals, even amphotericin B, to treat it. And so it's not super common. I'm not seeing it's like making the news, but I've seen several cases, which means if you see several cases, there's probably more that you don't see. And it's just become an issue because we have nothing to treat it with. And so people can make it through the surgery, no issues whatsoever, and then they pick up this particular candida in the hospital setting, and then they die of that. Nothing to treat it. Our third of our opportunistic pathogens is Aspergillus. Also found out in the environment. Usually found and picked up, usually soils that have lots of nitrogen, again, those that usually have lots of bird droppings, bat droppings. So people that own birds are at a high risk of picking up different fungal diseases. People that go into caves where there's bat droppings are at increased risk of picking up different fungal diseases that, other people that don't go to those places. So it's picked up through inhalation. And for a lot of people, they develop allergy-type symptoms. Sneezing, coughing, runny eyes. And so if you suffer from even springtime allergies, it might be a fungus that's actually causing some of those symptoms. I was going to say, underneath a microscope out in the environment, they grow on those long hyphae, but then they just don't have like one bud. They actually form like little strings of buds. I always think they kind of look like little flowers. Kind of. They're very unique looking fungus out in nature. Depending on, how it progresses, depends on which type of aspergillosis you have. Hypersensitivity aspergillosis are allergies. And allergies caused by this particular fungus. So hypersensitivity, that just means your immune system is overly sensitive to this particular fungal spore and it causing all of your allergy symptoms, the coughing, the sneezing, the runny eyes. Non-invasive aspergillomas means this particular fungus has gotten into the lungs and it is causing lung infections. And they will actually form in these little, clumps. They're called aspergillomas. But they'll grow in these little clumps. And they usually follow a TB infection. Tuberculosis actually creates these little tubercles, these growths in the lung that destroys lung tissue, where you actually have these big cavities of open tissue in your lungs. And this particular fungus is like, oh, what a great home. Thanks for leaving me that empty space. But as long as they call it non-invasive, because it's just growing in your lungs, but it's staying put in those little open cavities. Once it starts to leave those little open cavities and starts to travel throughout the body, now it's called the acute invasive. Invasive because now it's leaving the respiratory tract. That in itself is pretty rare. That's usually not going to travel unless you're more immunocompromised. You can still get hypersensitivity. You can still get non-invasive aspergillomas. This is usually reserved for immunocompromised. And so it can get out into the skin, and you can actually have growths of the tissue underneath the skin. So it looks like you've got these little growths underneath the tissue. It can also get in and start to grow on internal body systems, causing issues as well. Again, rare. And our fourth of our opportunistic pathogens is the Cryptococcosis neoformans. This is picked up by breathing in the dried yeast, so the spores, that are usually strictly in the bird droppings. So it's not just in the soil, but they have to be, recently defecated in the bird droppings. It is one particular reason why on rooftops of large buildings where the air intakes are, they try to do different things to not have birds near them. Whether they cover them, they put little spiky things, they put owls up there to try to scare birds away. The idea is that you want to try to keep bird droppings off of air intakes, otherwise this particular yeast could get inside of air intakes and potentially get into anyone that's in the building. Luckily, most people are asymptomatic. People that own birds, again, birders, any type of increased interaction with birds, even chickens put you at an increased risk of picking up these particular fungal spores. They do have a thick capsule, so they are harder for our immune system to get rid of. Just like a capsule on bacteria is harder for our immune system to get rid of. Most individuals suffer from what's known as primary pulmonary cryptococcosis, which means it just gets into the respiratory tract. Sometimes asymptomatic or mild pneumonia type symptoms where they can get a little bit of fluid in the lung, a little bit more difficult breathing, but it might be mild enough you wouldn't even get diagnosed. Those that are more severely immunocompromised, then it can get into the central nervous system, can cause meningitis. It can also travel out to the skin, and it can cause skin lesions. Again, usually for those that are more immunocompromised. Again, healthy individuals usually don't suffer much from this particular fungus. But it can cause skin lesions. Like this is a super extreme skin lesion. But otherwise, it can cause skin lesions all over the body. It doesn't have to just be on the face or where it was breathed in. Now, we talked a lot about in here, a lot of these fungal opportunistic fungi are usually opportunistic and usually found in AIDS patients. AIDS patients are the most vulnerable to fungal infections is because they have no effective immune system. That's what puts them in the AIDS stage of HIV infection. When you're in the AIDS stage of HIV infection and you get a fungal disease, there is no cure. Even if we give them an antifungal, the antifungal still has to work with our immune system, and the two together get rid of the fungus. They'll give them an antifungal to try to keep it, in check a little bit, but they will not get rid of the fungal disease. That most AIDS patients actually die of fungal diseases than bacterial or viral infections. And partly it's just because we don't have anything to treat. Certain fungal infections, because they are rare and only affect those that have no working immune system, will tell us that someone's in their end or late stage of AIDS, because they would only get these fungal infections if they have zero immune system. Generally, those that have HIV, they track how the immune system is going. I know we've got lots of really good HIV treatments these days to keep the virus in check. But a lot of times, those that have tested positive for HIV are just given a low-dose antifungal that they'll take for the rest of their life. Because fungal infections are so deadly to those that have HIV, they're just, okay, well, we're just going to give you this preventative antifungal. Mm-hmm.
But isn't the medication that not everybody that has HIV
that gets to the end stage that we know of, because the drugs are so effective. We don't, and they're so new, we don't know in 60 years if that they would eventually still change. But as of right now, you're right. They're keeping people that have HIV. The drugs are awesome because they stop the HIV from spreading.
So
and
does that mean they can't pass that on anybody?
In theory. But say 100%, no. But it does decrease their risk of spreading it. Doesn't always mean everyone takes their HIV meds routinely. If they don't have health care, if they're in different parts of the world where they just don't have them, then. So I know. It's like all these different ones. I'm like, I see commercials for them all the time now.
Well,
Yeah.
at the clinic and we had a walked out and was like, what's that? And she's like,
Yeah.
I did not know it was even.
Yep. Yeah, it is now. Again, are they 100% effective? No, none of it's 100%. And part of that is, and part of it too is they have to be taken almost kind of like a birth control, like very routinely, because if you just miss a day, it's almost like your immune system's like, oh, I forgot everything. And it would put you right at risk again. So that's why they're not 100% effective, but they are, awesome to have it if you can reduce any chance. We do also have a few new fungal pathogens that are only affecting those that have AIDS, a Fusarium, a Penicillium. Yep, it's a different species, but in that same group of fungi was where we got penicillin from, and then a Trichosporin beigeli. So some of these I don't expect you probably, unless you are working with those that have HIV and has developed into the AIDS stage, which means they weren't taking their HIV meds, you probably are not going to have patients that experience these, but wonderful drugs and great healthcare. Our last group of fungal diseases is the superficial cutaneous and subcutaneous mycoses. These are the ones on the skin. They are the most commonly reported. Any guess why? Why would a skin infection be more commonly reported than, say, you have a cough? Yeah, it's on your skin. You're probably going to you're like, oh my God, it's unsightly. Is a cough unsightly? No. And I'm like, people have coughs for so many reasons. It's like, I don't know. I don't need to go diagnose. I don't need to go tell them, I have a fungus, because it could be a parasite, or it could be, a virus. It could be a bacteria, whatever. But if you got something like calling an unsightly something on your skin, you are calling the dermatologist and then waiting 6 months to get in. So they're the most commonly reported because they're the time that people will actually go in to get diagnosed. Most of them are opportunistic, meaning if you have a healthy immune system, you usually don't suffer from a lot of these. Not always. They're usually localized, meaning wherever that fungus takes hold on your body in that skin, it usually stays put. It doesn't like to spread throughout the whole body, usually doesn't cover the whole body. They're acquired by touch. So these are acquired. They can be spread if you have fungus on your skin and you touch someone else, or you touch a surface that someone else touches. They're touched by skin-to-skin contact, or even skin-to-surface contact. They're not life-threatening. I mean, you may think you're going to die, because you have an unsightly fungal infection and probably somewhere you didn't want it. But they're not life-threatening. They're not going to kill you. Most of them are chronic, though, which means they're not going to go away very easily. And most of them, if you get a fungal infection one time, you're more likely to get it again. So, common ones, again, these are just fungus. They're just commonly called ringworm. Ringworm is not a worm. It's nothing to do with worms. It's like a horrible name they gave to it. I think it's because at one point, it usually forms a nice dark red circle around it. That's where they get the ring from. I'm assuming. At some point, they thought there truly was a worm underneath the skin. But it's not. It's a fungal infection. It's just spreading out from point, A, and then spreading out in all directions. Most commonly associated with wrestlers. Why wrestlers? I was going to say skin-to-skin contact. They're sweaty. It's usually warm. I was going to say, I don't know. I taught in high school, and they would literally turn the temperature up in the room where they would practice to sweat. So gotta lose that weight. There's just water weight. So you've got warm, sweaty, moist environment, lots of skin-to-skin contact, skin-to-mat skin contact, runs rampant. So now I'm they don't allow you to wrestle if you have an active ringworm infection. You got to take an antifungal, just a little cream, and it will go away. Athlete's foot, same type of thing. It's picked up by touching surfaces, usually found in warm, moist environments. So athletes, they're sweaty feet. They don't change their socks very often. They don't, put dry socks on shortly after. It's also picked up quite commonly in dorm showers. Again, all it takes is one person to walk into a dorm shower without shoes that's suffering from this, just fungal spores everywhere, which means everyone else that walks in there is now picking up fungal spores. If you may be slightly immunocompromised, you're more likely to develop the infection, but doesn't even mean you have to be immunocompromised. So as I always say, whether you're in locker rooms or anywhere, wear flip-flops. Anything that specifically feeds on skin, nails, or hair, so it doesn't mean it just grows there, it feeds on it, are considered dermatophytes. It means feeding on skin. And there are 3 genera of fungus that feed on your skin. The trichophyton, I forgot to know. Trichophyton, microsporum, and epidermophyton. Ringworm is technically a dermatophyte. Again, it's found on our skin, but it not only is found there, it feeds on the skin. And it causes that inflammation, that's the reddening. Dead tissue and keratin. Keratin is a protein in our skin, which means it's now an energy source for fungus to live on. And so our skin, our nails, our hair all have keratin in it, which means these fungi can grow and literally eat away at our skin, our hair, and our nails. And so nails, this is a fungus that's eating away at the actual nail itself, like a food source. It can trigger our immune system. Again, that's that inflammation, which can damage tissue over time. And it's spread person to person. Again, anything that's on our skin spreads, touching. Malassezia infections. It's not uncommon. I was going to say most people don't even know that they have this particular fungus on their skin. It's part of a lot of people's normal skin flora. It's called Malassezia furfur. I just like the name furfur. But this particular fungus feeds on melanin. Melanin is the pigment that makes our skin tan. And they develop what's known as pityriasis, which just means unmelanated areas on your skin. Where the melanin's everywhere, but you can see exactly where the fungus are, because all those little light areas is where the fungus is eating the melanin that's being produced. Diagnosing, you can do a visual diagnosis, but otherwise they can do a scraping on the skin and easily look for the spores. This is more commonly diagnosed in the summer. Why? Tan. I was gonna say you get a tan, but all of a sudden you're like, so even anymore, and then you go to the doctor. Right now, I'm at the palest you possibly can be because it's like the winter. That I don't know if I could tell what's unmelanated and what's just normal, at this point. So most people get diagnosed in the summer because you can see the difference in the skin tissue, and people want a nice, pretty tan. They don't want their skin to look like this. It's deadly. And I'm like, most people, this is part of the normal skin flora. You probably are like, oh, that explains so much now. Again, it's not causing any severe complications whatsoever. Treatment, and I'm like, for just a superficial infection of just a little bit of this, they'll usually just do a topical antifungal, little antifungal cream, no issues. If it's pretty extensive, like it's spreading everywhere throughout the whole body where you're just like, I have more unmelanated areas than melanated areas, then they would give you an oral. They would give you an actually antifungal drug. Like, I don't even know if they would go to amphotericin B, but like an itraconazole or a ketoconazole. But relapses are common. It's not uncommon that you're like, okay, I had this, I put cream on it, and then the next summer you're like, it's back again. It's part of your normal skin flora. It's going to keep coming back. I'm going to end right there because I probably have 10 more minutes to go, and I don't want to go 10 minutes over. I'm going to stop my recording now.